All right, we'll go ahead and get started. Dr. Carl Sash is a local physician who has been with St. Mary's Health since 1999. He is board certified in internal medicine and geriatric medicine with a special interest in hospice and palliative care. Dr. Sash is medical director of St. Mary's Palliative Care and with the Sarah Care in Evansville. So, thank you very much.
Thank you, Jim. Well, good morning, everyone. Good morning, everyone. Good morning. Thank you all for sharing your time with me this morning. And I certainly have had some experiences in hospice and palliative care, and we'll try this morning to share those with you. But I also recognize that I'm sure each one of you in this room has some personal experiences. An example is that I started this morning with my haircut at 6 o'clock. And Joe, the barber, and I were talking, and I told him I had this presentation coming up today. And I asked him, because I knew his mom had gone through hospice. She had been in a nursing home and had been declining from Alzheimer's. And I said, what did you learn out of that experience that you would try to pass on to someone else? And he shared with me that the experience was not a very good one for him. That for whatever reasons, the hospice agency that was providing care to his mother in the nursing home communicated solely to his brother, who was the power of attorney, to his exclusion. And it got to the point where they would just walk by each other, Joe and the hospice staff, and not even acknowledge each other, because he was really hurt that they would just sort of ignore him. And that made me sad to hear that this was just a year ago. This wasn't 20 years ago. That unfortunately the system, and I mean that sounds kind of dispassionate, but I don't know what other phrase to use, that providers failed to meet his needs. And I'm sure that many people in this room have similar experiences. I'm sure experiences that could be a lot worse. So I recognize that as a room, collectively, we've got a lot more insight and wisdom than I have as an individual, and we'll try to figure out how to make it dynamic together this morning. I'm going to start off by talking about the difference between hospice and palliative care, which may be a concept which is pretty familiar to some of you, although I confess sometimes even on a daily basis it's difficult sometimes to appreciate the subtleties, but I'll try to kind of lay out some framework. And one of the perspectives that I have is to talk about how the fact that as we think about the difference between hospice and palliative care, first off, hospice can be a great success. Hospice is now being provided, and these statistics are a little older, but the bottom line is there are an awful lot of people near the end of their life who are receiving hospice services. And in most cases, there are many positive aspects. Even in the case of my barber, Joe, his mother probably got some better care as a result of that. So there are successes. But the problem is that there are some failures. And palliative care is one of the ways that we're trying to address some of the shortcomings or some of the failures of only a hospice point of view. And again, a few of these statistics may be slightly adjusted now, but the bottom line is that the last data that I found that almost a third of people were on hospice for 3 days or less. So we're only bringing hospice in the final hours of somebody's life. And it doesn't mean that everybody needed hospice, but I think most of us in this room recognize they did. Another hospice failure is that, unfortunately, in the last decade, it's almost gone the wrong direction, where in the last month of people's lives, they're actually more likely to have been in the ICU. Now, if this is a younger individual who's fighting a severe illness, that may make great sense. But that's not the majority of the people we're talking about. We're talking about older, frailer individuals where most objective people looking on would recognize there's not very good chances that this person's going to survive, and yet there's still very aggressive care being provided. Now, we'll talk about autonomy, and it isn't necessarily wrong in any particular situation, but probably most of us in this room recognize it's wrong a lot of the time. Over a third of people who were in hospice had been discharged just 7 days previously from hospital. So again, we're getting people, we're doing all this aggressive care, then throwing them into hospice at the very, very end. So, and in hospice, often one of the big things that we worry about are these people who they just don't die the way we thought they were going to, and they stay on service a long time, but in reality, they make up a very small part of the pie compared to these people who, again, we're only getting at the very end. Similar data talking about how people are being moved from place to place to place, healthcare transition. So they're being moved from the hospital to the nursing home. They're being moved from the nursing home to the hospital or to the palliative care unit or the hospice agency, or being hospitalized multiple times. And most of us have seen the trauma that can go along for both the person who's ill and their family. More information talking about these transitions. So the bottom line, there was a big study that was published, and the lead author, this Dr. Tino, said, essentially what we're finding is that we're just getting more short hospice stays following a hospitalization where they often were in the ICU, and it's suggesting that the increasing hospice use is not reducing resources, and we're not starting with the assumption that we should be reducing the number of hospitalizations for any particular individual. But we're starting with the perspective that many of us believe that overall we're hospitalizing too many people. And I'm going to try to talk about, how do we help people with that process, because it's not simply a matter of saying no to people. What I'm going to get to is it's really about communicating to people. It's about listening to people, and it's about asking questions. But again, that we're seeing that hospice is just this add-on that we're now doing, that we're doing all of this aggressive care, and at the end of it, we're doing hospice as this afterthought. Like a very thin layer of icing on top of not a cake, but a really yucky combination of whatever. So, palliative care, what does it try to do? Well, it tries to address pain and suffering, quality of life. And the key is that it's trying to address this across stages of treatment, not waiting until the person has made the decision that they want to go on to hospice. And as a result, it doesn't exclude life-prolonging treatment and rehabilitation, which generally hospice excludes both of those. And the current model, although it's difficult to read, is that we have this curative or life-prolonging treatment phase, and then, bam, we switch to symptom control and palliative care. And in fact, really what I'm showing you is that for lots of people, this red goes to there. And then there's this little bit of blue. And a lot of us find that unsatisfying. Unsatisfying for our patients, unsatisfying for our loved ones, and unsatisfying as a prospect for ourselves. And again, this is this dichotomy where we go from doing everything to then all of a sudden we're comfort care. And that dichotomy fails to focus on the suffering and the quality of life that people are, that's the suffering and the loss of quality of life that people are experiencing through this process. And so, as a basic model, what some of us are trying to do is have more of a transition where, yes, we're thinking about curative or life-prolonging treatment, but even early on, we're thinking about symptoms and quality of life. And then with time, as we realize for a given individual, we're losing, quote, the battle, which is a poor analogy for many things. But as we're losing that battle and we're less likely to want to pursue curative or life-prolonging treatment, we're filling that with more symptom control, not just abandoning the person. Now, one of the challenges is that palliative care is often confused with hospice care. And so the challenge is trying to articulate in our own minds, let alone for somebody else. So one of the ways that I look at it is talking about non-hospice palliative care, which is again where you're in conjunction with the attempt to cure or prolong life, but you're still trying to focus on comfort and quality of life. Versus when you make that transition to hospice palliative care. And that's when you have recognized that life-prolonging or curative treatments are not successful, and you ultimately want to pursue comfort only. So again, non-hospice palliative care versus hospice palliative care. Because it's not like palliative care stops when you switch to hospice. It's just that it evolves. And one of the things that can be really challenging is that not all of our patients have the same progression of their illness or trajectory. Now, some illnesses are, quote, easy. Some cancers are, quote, easy. By which I mean that we can see that people have a fairly predictable period and sometimes have a fairly rapid decline. And please don't take away from this that I said cancer was easy to have or deal with, but it sometimes is a little easier to approach when you have a person or a family and you can say, well, we have a fairly strong likelihood you're going to make it 2 months or you're going to make it 6 months. And of course, we're not knowing the future, but we can predict with some confidence. Versus cardiac and pulmonary illnesses as one example, where frequently people experience episodic declines in recovery, and then unpredictably at some point an episodic decline in recovery, and repeatedly until the decline is actually enough that it takes their life. And again, it's sometimes more challenging to predict prognosis. And then frailty and dementia, where none of us have really much of an idea from day to day where the person's going to be. And some people can hover amazingly close to death, but stay alive for a long period of time. And it's just helpful to try to be as mindful as we can of what is the underlying illness the person is having so that we can anticipate better what to expect in the future and what to communicate to the patient and or to their family. And then, of course, the real-world experience is a lot more messy than that, where at one point it seems like the likelihood, at some point it seems like the likelihood that we're going to be able to cure things is less, but then things improve. And so for a while, we back off on the palliative care, and we recognize that maybe we're going to try this new chemotherapy, or maybe we're going to try this new drug for their heart. And then all of a sudden a person has a decline and we recognize that, oh, things are getting much worse and getting much worse. Well, but wait a minute, now they kind of stabilize. So the reality is that we have to continually adjust to how that person's status is, trying to make sense of their prognosis, but all the while trying to make sure that we're not just focusing on what are we doing to try to either keep this person alive or prolong their life, but what are we trying to do to make the life that they're living more enjoyable, have a higher quality. Because again, palliative care is all about living, not about dying. So maybe that would be, if you could put a bumper sticker on your car, if you could remember one thing from today, if you could pass one thing on to your patients or your loved ones, is that palliative care is about living. It's not about dying. And then one of the other challenges that I'm going to get back to is bereavement care. So when a person passes away, they're gone. But their loved ones still have a prolonged period sometimes of bereavement to deal with afterwards. And sometimes the things that we do as a healthcare team can make this easier or harder. And it's really complicated what we do in palliative care. We communicate, and we try to clarify goals of treatment. Now, doing those things is complicated, but the things themselves are pretty straightforward. And I think that when I started doing palliative care, I actually became a better listener. I think I was a good listener before I started doing what would be formally considered palliative care. But after I started doing that, I had to preach to myself. I had to remind myself to listen better. And one of the reasons was I had the role models of the palliative care nurses and nurse practitioners who I could see listening to people. And so I've learned that one of the things that can be the most valuable when I see a person in the hospital or I see a person in the outpatient setting is just asking, what do you know about what's going on? What questions do you have? What do you want to share with me? And then once you've, so I kind of have these in the sense in the wrong order, because once you've listened to the person, then you can try to help them clarify what their goals of treatment are. Now, we're trying to manage symptoms, and there's a long list, and I think in some of the other presentations, people are trying to address that more. So I can come back to that as people need, but the bottom line is a good palliative care person is thinking about all these different symptoms and frequently having to ask, because the person either may not want to bother you to complain about it, or they may be overwhelmed by one or another symptom or issue that they're just not able to communicate and articulate some other problems that are going on. And of course, one of the big challenges we have is that frequently people's cognitive status is impaired. Their ability to fully participate in communication and goal setting can be at least partially impaired. And if we don't articulate that as caregivers, we're not going to be able to really set goals effectively. And one of the things that I see the good palliative care nurses and nurse practitioners doing, and one of the things that I try to do is figuring out what other resources there are. So sometimes it's home health, sometimes it is palliative care at home. There are many different resources that we can try to bring to bear. And trying to integrate care across different settings. One of the things that we struggle with, that as a system, as a provider team, is that frequently when people go from the hospital to home or to the nursing home, that we're not doing a good enough job during that transition. And so that's a big part of what I see the palliative care nurses at St. Mary's doing on a daily basis, is trying to improve that care coordination, and particularly when we deal with transitions from one environment to another. And what's interesting is that sometimes people have a mistaken impression that we have to have one thing or another. But in fact, there are many experiences in which palliative care can demonstrate improved quality of care, quality of life and mood. And interestingly, in some situations, people who are in palliative care live longer. So there's this misconception that we're quitting or we're giving up, which is absolutely not the case. So the first bumper sticker that I had was that palliative care is about living, not about dying. The second bumper sticker that I would have is that palliative care and or hospice is not about quitting. It's not about giving up. It's just that continual process that we should be doing with our patients, our loved ones, of redefining goals of care. And the reality is sometimes our goals of care will change. But what, again, is interesting is sometimes if we end up deciding to forego some possible life-sustaining treatment, we may actually live longer. You know, we've all seen the person who decided to go for that chemotherapy and then they passed away as a result of the complications. And that's just one example. I've had patients where it seemed like they were going to pass away if they didn't go to the hospital. They pulled through. And then similarly, people who go to the hospital who pass away. So maybe the second bumper sticker, again, is that we're never quitting, we're never giving up, that it's just about redefining our goals of care, our focus. The third bumper sticker is we're never playing God. We're not making decisions about whether the person's going to pull through or not. We're simply trying to help that person, or if the person's not able to speak for themselves, help their family come to terms with what their goals of care are, and then accepting that we only have control over a small part. Mother Nature's got control of the rest, and the reality is that we can't guarantee the outcome. So if somebody wants to be a full code, that doesn't mean they're going to survive a code. So again, we don't necessarily have to pick one or another, that frequently living longer and being more comfortable actually go hand in hand. Well, and of course, one of the reasons the hospitals care about this is palliative care can save money. Why can we save money? Because we're doing more care and less technology. We're doing fewer MRIs, we're doing fewer surgeries. If it took more MRIs or more surgeries to improve quality of life, well, then we might have to do that. But if we can have a better quality of life by doing fewer, then that's a win-win. So palliative care is not trying to stop people from doing things, but it's trying to make sure that they really actually want to do the things that sometimes the system is pushing upon them. And of course it can be, what's that, ma'am? I'm trying to get audience and participation. Did you have a thought, ma'am? Yep, and that's where so the comment that I heard was that people don't know their own prognosis. It makes it hard for them to make decisions. And I'll come back to that in a few minutes, but there are many parts of the team that have to carry their own weight. That's certainly one where physicians need to carry their own weight, because by and large, that is often going to fall on the physician. And that's where we need to do a better job of being more direct with our patients. Sometimes that's my job as a palliative care physician, is to come into the room or come into a patient's home and try to give a realistic explanation of prognosis in as compassionate a way as possible. But we'll come back to that in a second. So palliative care can be done by nurses or nurse practitioners or by some physicians. Hospices pay for palliative care. Increasingly now, accountable care organizations, which is something like an HMO, are paying for palliative care. And of course, hospitals are paying for palliative care. So my wife asked me to take this slide out of the presentation. Comatose Orphans. And it kind of gets at this comment we just made. So one of the neurologists that I trained with in Canada, he was a very abrupt man. He was a very good neurologist, but he wasn't very good at dealing with people. And he recognized that, and he said he wished he had specialized in the care of comatose orphans. And he was right. He had the personality to deal with people in comas, and he had the personality to deal with people who were orphans. But I often think back to this as I realize that we're not taking care of people in comas. We have to interact with the patient. And we're not taking care of orphans. We have to interact with and take care of the family. And so not all of us have the luxury of being a neurologist specialized in training. That most of the rest of us have to accept this reality that we have to take care of the patient and the family. And families have many challenges. And of course, some of them mirror the challenges that a patient themselves has. Again, ignorance of their medical condition and or the medical options. Sometimes unrealistic goals. And that's all in the eye of the beholder, isn't it? What is realistic and what isn't realistic. And that kind of gets back to the first point, that we can, I guess, only define something as unrealistic if we've had a thorough discussion about what the medical condition and the medical options are. And if once we have a thorough common understanding, a person or their family wants something which is so unlikely based on this first part, that there are times when we can say this is unrealistic, or it sounds like you're denying what's going on here. Of course, all of us in this room have entirely functional relationships with all of the other people in our lives. So it will come as somewhat of a surprise to all of us that not all of our patients or our families are gifted with that luck. That clearly there are many of us, many of our patients who have substantial dysfunctions. Yesterday, a patient's daughter shared with me that she wanted to help me understand why there was just this weird dynamic that I didn't understand, where son and daughter were supportive of dad, but only to a point. And she shared with me, only so that I had the perspective, that dad had sexually abused son and multiple grandsons and had spent time in prison. And mom had ignored all of that. And that the children and grandchildren had cut off all ties with mom and dad. And then when mom passed, son and daughter made the commitment that they would at least watch out for Dad. They weren't going to reconnect with him emotionally, but at least they felt the responsibility to reconnect. Son still has no relationship with his children who have completely disowned him as a part of this whole process. So at moments like that, you just sit down and you count your blessings, and you realize that there are some, when we use the word dysfunction, that doesn't begin to encompass some of the challenges there are, and yet these people are family. These people seem to be serving as his next of kin and assisting in making decision making, and so I have to listen to them and incorporate them, and I want to listen to them and incorporate them in the process and respect the sacrifice they're making, which is far greater than I can even understand. Cultural and or different perspectives. This is a tough one because we never want to culturally profile people. We never want to assume, well, we can probably assume certain things about West Siders, but that's a whole nother discussion. We don't want to presume, and yet we have to be sensitive. And so there are certain cultures in which it's not polite to challenge the doctor. I'm not in that culture very often. There are some cultures in which you never let go, you never quit. And yet, not everyone who is a member of a particular culture accepts all of those realities. And not everyone that is a part of a culture that we would think doesn't have those necessarily doesn't. So it's a challenge to understand, to be sensitive to cultural differences, but not assume that that understanding predicts for a given person. And then bereavement and grief, which is, of course, ultimately the expression of all of these things put together. And again, that's probably our primary or ultimate responsibility to our patients' families is addressing the fact that once their loved one is gone, they're going to be left dealing with the emotional baggage. And the things that we do can have an important impact on how they do with that bereavement and grief. So challenges that providers have, well, sometimes people don't accept what we say. And we have to then get back to, am I communicating? Am I listening? Am I communicating effectively or not? One of the roles that I have as a palliative care physician is sometimes to come into the room to provide a different perspective, a different ear to listen, a different voice to try to explain to people. Because is there non-acceptance because they're just not capable of accepting, or is it the fact that the system has let that person down of not listening and not communicating well? When people are experiencing complicated grieving or irresolvable emotional reactions. So we had a patient not too long ago. His daughter, this gentleman was 94, and it was clear to everyone in the world except his daughter that he was dying. And it might have been clear to her, but she certainly couldn't articulate that. And in the middle of the room, over the bedside, she's getting in arguments with her brother, she's getting in arguments with multiple caregivers, she's coming out to the nursing station, she's yelling. These can be huge challenges. People sometimes have expectations that are excessive. From my standpoint, I've only got one mom in the world, I want everything for her. Versus the realities that an ICU only has a certain number of beds, and not everyone can be in them. Sometimes the team is not all on the same page. Sometimes the team, the nurses, the therapists, the physicians, the specialists, all the team members need to pull back. So not too long ago, we had a case conference over one patient that we felt care was futile. And it took some time to get everybody on the same page. And the palliative care nurses and myself have had situations where we thought that everybody was on the same page, the family, the patient, all the physicians, only to have one specialist come in the room and say, well, no, what do you mean you're quitting? This can be beat. So it is a big challenge and something that we sometimes have to work on. So how do we try to resolve these things? Well, the life experiences that we have, the training that we have are important. And sometimes we have to fall back on our guiding ethical principles. And there are fundamentally four. And I do find it helpful, even now, to sometimes stop thinking about the case for a moment and just fall back on these four principles And that allows me to then articulate better why it is that I'm advocating something. Because frequently my instincts are correct, but my ability to articulate it is not good enough. So the 4 principles we talk about are, number 1, autonomy. So within certain limitations, people have the right to make choices for themselves. And that's not a straightforward process. There are times when people's autonomy is going to be questioned for one reason or another. So we talk about a person's competency and whether they have the sufficient cognitive skills to understand a certain situation. And then we talk about their capacity. So one person may be competent to make certain decisions, but if they're acutely ill, they may not have the capacity to make that decision at that time. And there are times when different people are going to have different interpretations of whether a person has the right to make a decision about their own body in certain ways. But if we still think about that principle, it can help us. Beneficence, doing good. So the bottom line is sometimes I may be able to articulate to a patient or a family that I'm going to quit doing something. Like, I'm not going to code you because I don't think there's any benefit that will come from you and to come to you from that. And I don't believe that ethically I have a responsibility to provide something to you that I believe has no benefit. Now that's a complicated issue, and maybe that's dangerous for me to have thrown out about code status, but it's an example of how there are times when we do not necessarily have to provide something that does not have benefit. Maleficence, doing harm. So sometimes we tell a family, we're going to stop doing these things. We're not going to do arterial punctures anymore. We're not going to put in central lines. We're not going to cause this person more pain because it may benefit them a tiny bit, but if we look at the burden of care, that it so far outweighs any benefit that it no longer becomes a rational decision. And then justice, which is essentially saying not everybody can have everything. Again, the ICU's got 18 beds. There can't be 19 people in the ICU. And as custodians of the system, we have some responsibility to dispense the resources that we have. So, person who's got a headache who wants an MRI, maybe sometimes the answer I have to give is no, because it just doesn't need to be done. All of you can have it, but otherwise, no. And again, the tools are really simple, but using them is really hard. The tools are communication, at least I put them in the right order this time. Communication, and communication, unlike some of the people we know, communication starts with listening. I think we all know people who are effective communicators. I have one friend who, once he's had his 2 or 3 beers, will not stop communicating. It is, however, a one-directional communication. He doesn't appreciate interruptions, by the way. So communication starts with listening and asking questions before you then ultimately, once you've done some goal setting, then communicate in that direction what your recommendations would be. One of the challenges we have is who gets to decide. So sometimes a person can try to exercise their autonomy, and they might be able to make decisions for themselves still. Or they might have created one of several different ways to try to express their wishes ahead of time. And that could be an advanced healthcare directive, a durable power of attorney, or a healthcare proxy. And sometimes people have all of those or multiple. So they may have an advanced directive, but then they might have some sort of healthcare proxy. And one of the interesting things is, depending on how the person's durable power of attorney is worded, that might give the durable power of attorney authority to override the advanced directive. So there are situations in which people might have an advanced directive that they don't want a feeding tube, but they've made someone their durable power of attorney for healthcare. The durable power of attorney for healthcare gets to trump that. And so as we counsel people, and I'm by no means an expert in this process, but as we counsel people about how to lay out their wishes ahead of time, they need to be mindful of that. So I have a patient who's on hospice right now in one of the nursing homes who was under the impression that she had to make somebody a power of attorney, and she was going to make her sister a power of attorney. The only problem is that her sister thinks that she should be off all narcotics, off hospice, and I guess out in the garden planting flowers. And none of these things are, as far as I can tell, realistic. So I had to explain, you're welcome to make your sister your power of attorney if you wish, but you have to be aware that you can probably do the same thing with an advanced medical directive of some sort. And if you do want to make your sister power of attorney, you need to recognize what restrictions you want to put. So then an even bigger challenge is that in Indiana, there is no formal pecking order of people who can decide as next of kin if the person does not have either an advance directive or power of attorney or someone designated as a healthcare proxy. Your spouse, your parent or parents, any of your adult children or an adult sibling all have an equal voice. And that's fine if they're all saying the same thing. Well, it may not be fine, but it's more straightforward if they're all saying the same thing. In palliative care, sometimes we're having to resolve the fact that not everybody's on the same page. And how do we get them to the same page? Well, in the magical world where everything works right, we communicate and we goal set. And in the world where we try communication and we try goal setting and ultimately that's not working, we fall back on these things to try to be our principles of how do we proceed. So a couple key points. So palliative care is addressing pain, suffering, and quality of life across all stages of treatment. So that would be non-hospice palliative care as opposed to the hospice palliative care. Another point, and here I'm probably preaching to the choir, at least in this room a lot, more aggressive care at the end of life does not necessarily improve quality or duration of life. The first step in communication, well, I didn't word that quite right. The first step is to initiate communication and to listen. And then through that listening and through those the questions you ask, helping people establish goals of care. And those goals of care have got to continually be revisited and readjusted. If you're walking in the wilderness and you have a map and a compass, you start the morning, but every once in a while you like to check the map and check the compass and see that you're on track and find out whether you need to readjust your route. That most differences in opinion or perspective can be resolved with communication, with reevaluating the goals of care and focusing on those four principles. Not all. Not all. We, in palliative care, and I'm sure many of you in this room have been in situations in which there are differences of opinion that will not be resolved. And then ultimately there has to be a process of going through our ethical perspective to try to decide what is the right thing to do. So unfortunately my oldest son is not in this picture, but this was the most recent family picture that we have from Easter time. This is the 20-year-old who's now down in Florida at college, and the 19-year-old who will be at IU, my long-suffering wife, Angie, and the 25-year-old, I'll try to bring a picture of him next year. Well, thank you for your listening. And what I want to do, I guess, at this point is open it up to the thoughts and experiences that the room has, the questions, and I'll be quite prepared to not necessarily have the answer to your question, but maybe somebody in the room will have an answer. But let me start and see what thoughts, questions, experiences any of you have. Yes, ma'am. So I'm going to repeat your comment and your question just so everybody in the room can hear. And I may not get it all exactly correct, but let me preface it by saying I've come to believe that the single hardest thing for most of us as we get older is losing loved ones. Because those of us who are, quote, lucky enough to survive, we've lost the people who weren't so lucky. So what I think you were describing is that your husband is gone, that your biologic children are gone and siblings are gone, that you have an aunt and you have a stepdaughter. I can't comment with complete certainty as to whether your stepdaughter would be recognized. I think that it would depend on the nature of your relationship. And if you have a strong relationship and a strong bond, it would be my understanding that both from a practical standpoint and a legal standpoint, her position would be recognized. That it is, she may not be a biologic adult child, but as a stepchild with a long-standing relationship, and there's evidence to people around you that that relationship is ongoing, and that any reasonable person would think that she speaks on your behalf, I would believe that there would be both a formal recognition and a legal recognition of that. But it probably would be prudent to set that down in an advance directive or a healthcare proxy, so that even for a day or two, someone who's too concerned with being too correct with the rules isn't maybe missing an opportunity to help you by listening to her. So yes, I think the way it would work, I would imagine, would be that she would be recognized, but there probably would be no harm in designating her. And maybe in that document, you designate, if she's not available, who's the second person? Because, and other people, maybe somebody can educate us here in the room as to whether those kind of resources are available online for free. In other words, I would hope you don't have to spend a substantial amount of money with an attorney to do that. So if anybody knows of that, they can speak up now or come up afterwards. Have you? If you've done it, then I think it should be set. Okay. Any other? Yes, ma'am. So the question is whether it is going to pose any problem to have someone who is out of state act as your power of attorney. None whatsoever that I know of. You know, there are logistical challenges, but there should not ultimately, you know, if your power of attorney is in San Jose and I'm talking to them on the phone and they give me directive, that should be all I need. You've designated them to speak to you legally, so I'm not aware of any limitation that places. Yes, ma'am. Well, and so your name, ma'am? So Carol was just sharing with us that by her friend designating her as a power of attorney, even though her nephew was not comfortable with that because Carol wasn't family, that Carol was able to really probably provide a better assessment for her friend of what decisions she would want to make through the process. And you're right, you know, even if the nephew had decided to challenge it, you would think, and of course a legal process is its own thing that I can't necessarily anticipate, but you would think it shouldn't matter. That if she signed a document designating you, that should be the end of the discussion.
There are parish nurses out there that have been trained in advanced care planning that help guide individuals through the process on how to approach people as healthcare power of attorneys. So you might check with your faith community to see if you have that available within your community, because there's a training session out of Gunder, Wisconsin, where the parish nurses do some online training, face-to-face training. And so you might check and see what's available within your community.
Would one of you be able to stick around for a few minutes afterwards in case anyone here would like
Yes.
that resource? Great, thank you. Yes, ma'am. Oh, Mike. Tim with the mic is going to be there.
So I wanted to see if you had any specific guidance about talking with patients about end of life, particularly code status. I work in a hospital, I'm a resident, and often when I admit patients, we ask them about code status. And even when I talk to my own family members, people often say, if you think I have a reasonable chance, then do everything. And do you have any suggestions about the next step in that conversation, which is, you know, that's not exactly how it works. We have no idea if you'll have a chance or not, but just kind of where to go when people say that comment, because I hear that a lot.
Yeah. Well, I'll try to address it in the way that I know. And first is, one of the things that I tell people is, this is kind of bad to talk about, but the only thing that's worse than talking about it is not talking about it. And the challenge, of course, is when somebody's being admitted to the hospital, frequently you're asking a 55-year-old healthy man or woman who doesn't take any medicines, who's having a routine procedure, whether they want to be coded. And if they say no, you're like, are you kidding me? So on the one hand, it's this routine thing, and unfortunately gets treated as sort of a rubber stamp thing frequently. But I actually would disagree with part of what you said, which is that we have no idea. Frequently, we do have a pretty good way of predicting. And so if you are comfortable making that assessment, so someone who has an advanced incurable illness, particularly cardiopulmonary illness, which is going to affect their ability to be weaned off the ventilator, or if they have an advanced malignancy where their prognosis is uncertain or pardon me, is poor, clearly there are some situations in which we can know quite confidently. There was an ER doc that published an editorial, and he showed some statistics that I think it was about 5% of people who code in the hospital will be outside of an institution a year from now. So one of the things that I find valuable to talk with my patients about is not whether they're going to live or die, because that is kind of a one way or the other situation, and you're right, maybe it's a little hard to know, are they going to survive that code? But what I can honestly tell a lot of my patients is, we're going to do everything we can within reason. However, if it comes to the fact that your heart stops or your breathing stops, and we have to try to perform CPR or put a tube in your throat, the chances that we are going to get you back to anything like the quality of life you have right now are extremely small. And the likelihood that you will end up any better than in a nursing home is extremely small. Now, I try to be careful because I try not to phrase it in that way to intimidate them or scare them, but those are the things that I find my patients care about. They care about, am I going to get back to where I'm at now? And am I going to be disabled in some meaningful way? And one of the thresholds for disability is whether you can live independently. So if the person's medical condition is such that you feel confident, based on your assessment, that you could say some version of that, then it's very reasonable. And if you're not sure, you could say, well, you know, we might want to put you down as a full code right now, but maybe we should talk with your cardiologist and say, or your pulmonologist, or somebody else, or it could even be your primary care physician who's known you for a while, and ask them whether they feel that if it was you, that if they were you, they would want it done. So that's the best approach that I can generally use. Based on what I've just said, are there other thoughts or questions that you have on that process? Yeah. Sure. Well, but if she, well, yes and no, because if she is cognitively intact and her cardiopulmonary status is pretty good, it's going to depend on the nature. And the thing I would keep in mind is that the whole goal is not to make people allow natural death. Like if the goal was just, okay, we're going to make them allow natural death /no code, and oh, our job's done. we're good. No, of course, we all know that it's not. That the first issue is trying to address code status, but and trying to decide one way or the other. But sometimes the issue with your family is not, like with your 85-year-old grandmother, is not to really kind of stress yourself about the code status, as much as to say, okay, but let's lay out so that we know what are the situations in which you would want us to stop, or you would want us to ask the doctors to stop. So are you going to want a feeding tube? If you're on the ventilator for 3 days and you're not getting better. So you might have that kind of discussion so that, because there are, a number of situations which are conceivable, some pretty bad pneumonia, or maybe she gets an SVT or something where she does need to be briefly intubated, but she actually could recover. Maybe the issue for her, since she's pretty healthy, is, okay, where should we stop? And that discussion at least will prepare the two of you. I used to say that advance directives weren't worth much, except that they facilitated a discussion with family members, with loved ones, to try to, so that the person gets a chance to educate family about what their wishes are. I still believe that's really true and really important, but I have recognized that in a few situations in the hospital, in the ICU, having that advance directive is really important, because there are times when surrogate decision makers are trying to make a decision which really ultimately is not consistent with what the person wished. And it is occasionally helpful to say, I respect what you wish, but this advance directive right here says different. And that person, unless you're a durable power of attorney, gets to speak for themselves. So don't worry about the code status as much. Just have that discussion about, okay, well, what are your goals? And where would you want us to stop, just so we know, so that we don't feel guilty that we're pulling the plug on grandma. We'll know that we're following her wishes. Yes, ma'am. Yeah. I agree. And in fact, the first little while that I heard that phrase, I kind of thought it was just trying to put window dressing on something. And I've come to accept that it's not. That allow natural death is a much more appropriate term. It's a natural term as opposed to a medical term. And it isn't the absence of doing something. It is the acceptance, ultimately, frequently, of reality. Did you have a question? Sure. Well, there certainly is a palliative care presence within St. Mary's for our pediatric and neonatal population. Because the emotional realities and medical realities of that are so different than adults, it's not something that we as the formal palliative care team become a part of. The pediatric intensive care unit, the neonatal intensive care unit have resources with regard to that. So you're right, palliative care unfortunately sometimes has to be applied across all ages. But I do believe that at least within the walls of the hospital, because frequently if a child is that chronically ill, they're probably that severely ill, they're going to be in the hospital. And there are situations in which our outpatient palliative care team can be asked to help in the care of a child who maybe has a chronic illness. We so far have not necessarily been able to meet that need, and it is a limitation in the outpatient setting. And so you're correct that that need is there. Yes, ma'am. Yeah. So the question, what does palliative hospice care mean for someone who has dementia? Sometimes it means something different day to day. Sometimes it means that the aide is coming in, giving a bath. Sometimes it means that the nurse is there checking on medication. So sometimes it is that there is a change in the person's day-to-day care. Sometimes a big part of what it is establishing that safety net, establishing that support system so that if that person with dementia gets pneumonia or stops eating or has some other acute complication, that there's that support structure in place. Frequently, it's been valuable when hospice has been involved before that acute moment so that the relationships are developed between the caregivers and the decision makers and the hospice team so that they can better communicate and better support each other. The diagram I showed earlier is an illustration that it is challenging sometimes to predict a person's prognosis, whether they're going to pass away in the coming 6 months, for lack of a better number. And yet, there are certain things that we can look at that do predict that. A person's had pneumonia, a person's getting skin breakdown, a person's losing weight, maybe getting repeated other infections, or having more problems with aspiration. So there certainly are things that we can look at which do predict that that person may be in their final time. And again, sometimes it's clear that palliative hospice care makes a difference day to day in that person's life. Sometimes it doesn't, because the truth is that their caregivers, be it in a facility or at home, are doing a wonderful job providing care, and that really the only job that hospice has got is building that relationship, building that rapport. And the reality is that Thursday night at 2 in the morning, when this person has a pneumonia and starts having a respiratory rate of 40, that hospice nurse is there at 2 in the morning, and I'm prescribing Roxanol, and the family's picking it up, and what could have been a very, very difficult final few days becomes something much, much better as a result. So that's, I guess, you know, and again, providing that bereavement care, because some people whose loved ones pass away from dementia, that is a very easy process of letting go. They've been letting go for a long, long time. At least one of the people in this audience, who's a very dear person that I know, had quite a very different experience where her husband passed away with dementia, and it was a very difficult decline. And I think hospice you know, made a difference, but it still was very difficult.
I just wondered whether to have a patient whether to offer that, because I've often wondered about that. It seems like the first thing that people do is put them in a unit or something.
Yeah.
Sometimes it seems really sad.
Well, if a person has Alzheimer's and it follows a predictable course, they are going to either need a hospice unit or skilled nursing unit or equivalent level of care at home long before they're eligible for hospice. When a person is, if a person has Alzheimer's, when they start exhibiting the kind of behaviors which either require an Alzheimer's unit or a skilled nursing unit or that level of support at home, they likely still have several years to live. And as such, they would not necessarily be considered eligible for a hospice benefit through Medicare or otherwise. And also, in part of that is that hospice is really intended to support the symptoms that go along with ultimately the terminal period of a person's life. Because hospice nurses, it's true, are good at dealing with agitation and aggression and some of the other symptoms that people with Alzheimer's can have. It's really generally more in the context of when that person appears to be in the last part of their life. But I think, again, if you think in terms of that Alzheimer's patient that is losing weight, is getting to the point where they're starting to have skin breakdown because they're so immobile and they're so malnourished, or they're getting repeated infections, where it really looks like you wouldn't be surprised if in the next few months you got a phone call that person had passed away. It can be very appropriate to recommend that the person consider hospice services. But their expectation should be that hospice is not going to come in with an agenda. No different than what I've talked about with palliative care, hospice has to be palliative care plus more resources. So hospice has to come to this situation and ask questions and listen and try to formulate a plan of care that is centered around that person or their decision makers' goals of care. One of the problems, of course, that we've all observed is that, unfortunately, sometimes for different reasons, any particular organization, be it a hospice agency or otherwise, kind of comes in with an agenda, comes in, okay, we're going to, no, I mean, then we're not doing our job right if that's the case. And a person always has the right to quit hospice. You know, say you decide you want to initiate that, and if you feel that hospice is dictating things, you can say, you know, this isn't working. Because, yes, I appreciate your help, but I want your help, not you taking over. What time is it getting to be, Tim? 11:30. Oh, we got lots of time. Other thoughts, questions, or concerns? What's that? Time for lunch. Well, it is true, it's time for lunch. And no one in this room is going to offend me or anyone else if you go for lunch. But in the same time, there may be people who have other questions. So please, right now, anybody who feels in the mood, get up, because I know that an hour with me is amazing, but more than an hour can sometimes be a bit much. So why don't we give people a minute or two. I'm going to stick around. I'll keep the mic on so that if people have other questions or thoughts or concerns, we'll discuss those. But in the same breath, people have other places to go and other things to do, and nobody's feelings are going to get hurt. Thank you very much. And thank all of you for coming and for contributing. Yes, ma'am. Well, so the question of when to use occupational and physical therapies within the context of palliative care and or hospice. And the answer, I think, is really going to come down to whether the person has the cognitive and physical capabilities of participating in therapy and getting benefit from therapy. So some fairly common situations in which we'll involve physical therapy is caregivers are having difficulty transferring this person in and out of bed or in and out of a wheelchair. Or we need advice about what is the appropriate type of wheelchair or otherwise. So sometimes it's a fairly targeted issue. Palliative care is completely compatible with every therapy because palliative care, as long as the person is deriving benefit/pleasure from therapy. Now, clearly, we've seen situations where people are not enjoying therapy. They're not motivated. And it kind of gets at that whole question of what is pain versus what is suffering. And the reality is sometimes pain can be pleasurable if we feel like we're accomplishing something. We're working through pain to get stronger versus if we don't feel like we're accomplishing something, we don't have the same sense of benefit, pain, which sometimes is brought on by activity, which is what therapists are all about, is actually a form of suffering. So I think palliative care should always be consistent with therapy if therapy is consistent with the person's goals of care. There are sometimes realities of hospice where the hospice agency, kind of getting back at the sense of justice, the hospice agency has a certain amount of money that they can spend. And I don't think therapists are that expensive, but therapy can be expensive because, of course, there's that structure, that billing structure that goes around it. And so frequently, any kind of prolonged course of therapy would not be consistent with hospice. Not because they're opposed to each other, but it is sometimes a matter where we kind of have to choose. So palliative care, we don't quite have to choose as much. We're trying to help define choices and goals. But hospice sometimes what I tell people is that hospice is three things. Hospice is when, one, you make the decision you care more about comfort than you do about cure. And then secondly, it's the agency that provides it. And third, it's the benefit that Medicare or other insurances provide to pay for that agency. But again, it's where you've really clearly made the choice, I care more about comfort than I do about cure. Whereas in the palliative care phase, often we're struggling with, well, what are my chances for cure? What are my chances of comfort? So palliative care and therapy completely compatible as long as it's consistent with the person's goals. Thank you so much. I'm going to turn the mic off. I'll stay around here for a few minutes up front. And if anybody has other thoughts or questions, they're welcome to come on up.